Hi, my name is Craig Feldman. I'm an orthodontist at the Smilist, and today we're going to talk a little bit about the orthodontic protocol at the Smilist. Basically, it's what the orthodontist of our company is looking for in terms of treating our patients. First of all, an orthodontist is involved with the growth and development of the jaws and the teeth, how the teeth align, how they line up, how the eruption patterns are going in individual patients. These are different for everybody, and we need to look at the differences and try to determine exactly what the patients need. The American Association of Orthodontics recommends that all patients be screened by the age of 7. It's easy to first think about what the normal patient has so that we know what is right. First of all, a class 1 occlusion is what we're looking for the canines and for, more importantly, the first molars to be lined up evenly in the jaw. We are also looking for lots of spacing of the primary teeth. Some people call this the ugly duckling stage because there's a tremendous amount of spacing in the arches. The reason this is good is the permanent teeth that are underneath those teeth are larger in size. So when the teeth fall out in their space, there's enough room for those teeth to erupt into place. When we see a child that has very, very straight teeth in the primary dentition, it often causes concern for us because we know that in the future these patients are going to have trouble with all of their permanent teeth coming into alignment properly. The first thing that I look for is the occlusion of the patient, namely class 2 and class 3. For class 2 patients, those are patients with severe overbites. We want to look at those patients and we want to determine why those patients have the overbite. Is it a skeletal problem? Are they growing that way? Or is it just simply a matter of the teeth are just forward of where they belong? Also, we look at class 3 malocclusions, which is an underbite. We want to know, again, why is that patient growing this way? Is it skeletal, which is the most difficult orthodontic problem to treat, or is it merely a functional bite of the patient? Again, the orthodontist is going to be the one that's going to determine the exact problem and whether treatment needs to be started early or not on these patients. We also like to look at crossbites. I'll talk about posterior crossbites first. Basically, what happens with posterior crossbites is the upper jaw grows too small and constricted, and as a result the patient, the early patient, looks to hit something with their teeth. This constant shifting causes what we call a posterior crossbite, meaning the upper teeth in the back are sitting inside the lower teeth. It's critical to correct this problem when we see it, typically with a palate expander to widen the roof of the mouth and take those teeth out of crossbite. The anterior crossbite is another problem that we like to look at. What an anterior crossbite is doing is the upper tooth in the front is sitting in behind the lower teeth, pushing on it. As it does this, it destroys the attached gingival tissue of the lower teeth in front of it. Again, this is a very simple fix with a retainer that pushes the tooth up and over and gets the tooth out of crossbite. Once the tooth is out of crossbite, there will be no more destruction of the gingival tissue, and it can't relapse back because it's basically the upper tooth is hitting the lower tooth just like a retainer. So it just stays in place. Again, these two problems with posterior crossbites and anterior crossbites are not probably going to prevent orthodontics in the future, but they're dealing with early problems that will cause major problems for the patient's dental health as time progresses on. I also like to look at deep bite cases, meaning the upper teeth are completely covering the lower teeth when they're biting. Again, this looks innocuous, but oftentimes it isn't, meaning that the lower teeth are banging on the bone of the roof of the mouth, and it's hurting the bone overlying the front 4 teeth. So we want to oftentimes open the bite or just get those teeth out of harm's way. Again, sometimes a simple retainer will help that. I also am constantly looking at eruption patterns of teeth, when teeth need to come out, primary teeth, if there's going to be certain problems with eruption of the permanent teeth, we want to kind of steer some teeth in the right direction. So sometimes early extractions of primary teeth is necessary in order to help that out. Again, those referrals would then go back to the general dentist to wiggle out some of the teeth. Also, if it's a very young patient, we can refer to the pediatric dentist of the practice in order to manage those teeth that are coming out. Space maintainers sometimes are required when primary teeth exfoliate or fall out earlier than they should. Again, the main one that I always look at is the mandibular primary second molar. The early loss of this tooth is a major problem if space maintenance is not performed immediately. The first molar typically tips into the spot where the tooth has been lost, and the eruption of the second premolar becomes compromised. So as long as a space maintainer is put in, it is very simple to prevent the tipping of that molar, and thus you do not lose the space. Also, that tooth, the primary second molar, is wider mesiodistally by 1.5 millimeters on each side to the permanent premolar that's erupting into place. When that space is preserved, again, if there's crowding issues in the lower arch, you can utilize that space to resolve those issues without taking out permanent teeth of the patient. I also like to look at whether a patient is congenitally missing any permanent teeth. Besides the third molar, I like to look at the maxillary lateral incisors and whether they're present or not, or the mandibular second premolars, again, whether they're present or not. These are decisions that will be made in the future on how to replace those teeth, but at least we can discuss with the parent and put into their heads the notion that an implant or some type of prosthetic replacement of the teeth will be necessary in the future, so that they can at least begin planning for these things early on. And then the final sort of orthodontic problem that we look at is what we call ankylosed teeth. Oftentimes these are in cases where the permanent teeth below the primary tooth is missing, and the periodontal ligament of that primary tooth is gone. And what happens is it becomes in contact with the bone, the root becomes in contact with the bone of that tooth, and it becomes stuck in that bone and not gonna come in or exfoliate properly. When that happens, oftentimes there's bone loss in between the ankylosed tooth and the permanent first molar. So oftentimes with ankylosed teeth, we want to remove those teeth early, and then again place space maintainers until the child is ready for braces. I think overall as a company we want to take a conservative approach. Not every child will need early orthodontic therapy, but the ones that do need it, we need to act on appropriately. Again, the orthodontists in the company will be able to make those proper decisions, and I've laid out specifically in the manual what conditions we're going to treat early and which we can wait and watch. The second aspect in the company, orthodontic-wise, is Invisalign. There's very specific guidelines and criteria to what we're looking to treat as an orthodontist with Invisalign versus what the general practitioner can treat with Invisalign. As a general rule of thumb, the orthodontist can treat any case with Invisalign that's appropriate, meaning they can treat class 1 crowding deep cases, class 2 cases, and even class 3 cases. Extraction cases will need to be dealt with on a case-by-case basis, and each orthodontist will determine whether or not they're comfortable treating extraction cases with Invisalign. Extraction cases in general should not be treated by the general practitioner. The general practitioner should be looking to treat class 1 moderately to mild crowding cases or overall spacing in both arches. The general practitioner should feel free to consult with the orthodontist either regarding their clean check or whether the case is appropriate for them to treat. The orthodontist should be very helpful to the general practitioner, encouraging them to treat cases themselves and go so far as to help them treating those cases, even if it means seeing the patients for a while with the general practitioner until they feel very comfortable treating Invisalign cases. The final aspect of the protocol that I just want to touch briefly on is the financial arrangements of the patient. I believe that all finances should be discussed with the parent and the patient and the orthodontist themselves at the consultation appointment. The orthodontist should know from the front desk what insurance information that patient has. Then the broad strokes of the financial agreement should be gone over with the orthodontist and the patient or parent. This way, when they get to the front desk, they know exactly what their responsibilities will be in terms of the finances with orthodontics. And again, it needs to be stressed to the front desk that the patients should be seen on a monthly basis and the payment plan structure should be on a monthly basis. If those patients are not seen for whatever reason on that month, that payment still needs to be made for the treatment that's being done. That's a critical component because we don't want patients falling behind by months at a time and then having to pay large sums of money. It's much easier if we can manage the finances on a monthly basis with those patients. I believe credit card authorization forms can be given and put directly into the computer if it's easier for the parent to not have to worry about making monthly payments, and we can automatically deduct those payments. But that's basically the protocol for the Smilist orthodontic program. My intent was to create a system that was universal at all offices so that no matter what where or what you're treated the same, whether it's in a Rockville Center office, Woodside office, it doesn't matter which office you're seen in the Smilist. The work will be the same, the products will be the same, and the rationale on treatment will all be the same. Thanks.